Hi, and welcome to Procedure Ready OBGYN, a podcast aimed at helping you excel during your clinical clerkship in OBGYN. My name is Dr. Jennifer Dory. I'm an assistant professor of obstetrics and gynecology at the Johns Hopkins University School of Medicine and former resident at Thomas Jefferson University Hospital. I'm the founder of Procedure Ready, a collection of resources aimed to advance your clinical medical education. Let's get started. Welcome back. Today we're going to talk about postpartum hemorrhage. This is one of the key obstetric emergencies that most students will have the opportunity to see during their time on labor and delivery. The definition of a postpartum hemorrhage, we're going to start there, is defined as blood loss greater than or equal to 1,000 cc's of blood within 24 hours of delivery, or less than 1,000 cc's with vital sign changes. Previously, the most common definition was greater than or equal to 500 cc's for a vaginal delivery and greater than or equal to 1,000 for a C-section. But now we have one unified definition, so greater than or equal to 1,000 cc's within 24 hours of delivery always counts, or it can be less than 1,000, but with significant vital sign changes. Postpartum hemorrhage is one of the most common obstetric complications, and one of the most serious too. It's still the leading cause of maternal mortality in the world. So we're going to get into the main causes and then what we do about postpartum hemorrhage. In addition to seeing this on the wards, you guys will probably also get questions about this on your shelf because, like I said, it's a huge maternal mortality issue worldwide. And so this is something that not only obstetricians, but family practice doctors and anybody who might be in a third world setting where deliveries can occur need to really know about. Also, all the medicines we use for this are pretty niche in that we really only use them in OB. So a lot of these are going to be new, even if you've done several rotations before. Okay, so let's jump into the causes. There are 4 T's that are the main causes of postpartum hemorrhage. The first one, and it's the answer 80% or more of the time, is atony, uterine atony. So the T for that is tone. So tone, or lack thereof, in this case, atony, will cause the majority of postpartum hemorrhages. So most of the meds and things we're going to talk about are going to be to attack the uterine tone. The other T's are trauma, which typically takes the form of lacerations or hematomas, tissue, so retained tissue, so typically placenta or membranes, and then thrombin is the T that makes it work really for any type of coagulopathy. There are some other causes that you'll hear in passing: uterine involution, accreta spectrum disorders, infection, things like that. Those are either secondary causes or just far less common, so probably not things that you're going to get asked about on the wards. But we're going to go through the most common stuff within postpartum hemorrhage, the things you're most likely to get asked on the wards, and then the things that'll probably also show up on your shelf. Okay, so you just participated in a vaginal delivery, baby came out, the placentas come out, and then as soon as the placenta came out, you start getting this heavy vaginal bleeding. So every time you do your uterine massage with your hand on the top of the fundus, you're like, holy moly, there are gushes of blood. You look over your shoulder and make eye contact with your resident to be like, I don't think this is normal, and they're probably going to take over. The first few things that just about everyone's going to get after a delivery is one things I just said, the bimanual massage or the fundal massage. So what we do first is hand on the belly and see if you can feel the uterine fundus. If you can, great. If they're actively bleeding, we'll put a second hand in the vagina to put it back behind, a couple fingers back behind the cervix to really compress the uterus between our two hands, making it thus a bimanual, both hands, and that do a massage. So massaging between our posterior hand in the vagina, pushing the uterus up, and the top hand on the uterine fundus, pushing down and massaging between the two. Physically irritating the uterus usually helps with tone. You'll see us also do this much more obviously during C-sections. Somebody will be actively like rubbing the uterus while we're waiting for the next stitch, or if there is bad tone and things like that. So everyone pretty much is going to get some form of bimanual massage or fundal massage, and even if it's just to check the tone and make sure it's good. And then Pitocin is the other big one, or oxytocin. So just about everybody's going to get a standard dose of oxytocin postpartum. If they don't have an IV, say somebody comes in and precipitously delivers, they don't even have an IV yet, we can give IM Pitocin, 10 units IM, but most people are going to get a drip or it's going to be an IV infusion. This has been shown to decrease total blood loss around delivery and doesn't increase complications. We actually start the Pitocin before the placenta comes out. So there used to be some worries about starting the Pitocin beforehand. Would that increase your risk of retained placenta? Would it cause additional complications? And the answer is no. So the placenta should, or the IV Pitocin should really start running just as the baby is delivered. And then it is running that whole time to help improve your tone and decrease your hemorrhage risks. So you do your Pitocin, you do a massage. It's not looking good, bleeding quite a bit or more than you'd like. We're going to move on to our additional medications. There are 3 medications that really target the uterine tone. The first one is Misoprostol. This is a medication you're going to come across in several GYN settings in addition to OB, but really not used tremendously outside of the OB/GYN field. So we use Misoprostol within OB for postpartum hemorrhage, as we're about to talk about, for induction of labor, and to help with any other type of evacuation of the uterus. So for things like a missed abortion, an incomplete abortion, or even a therapeutic abortion, we can use Misoprostol as part of the medication regimen to treat those things. So but the doses are very different. So for an induction of labor, for example, we use 25 to 50 micrograms. For postpartum hemorrhage, we use either 800 to 1,000 micrograms. Misoprostol is best absorbed through mucosal surfaces. So that can be buccally, vaginally, or rectally. You can swallow it, but the pharmacokinetics are just not as advantageous. So you'll see most of the time when we administer it, we are going to recommend one of those 3 routes: buccal, vaginal, or rectal. During an acute postpartum hemorrhage, 1,000 micrograms is 5 different pills. And if somebody is actively hemorrhaging, it can be risky to have them take it buccally if they are at risk of aspiration, if they could, have changes in mental status or consciousness, or if they could need intubation or anything like that. You obviously don't want any foreign bodies in the mouth. If you're doing this on the early side of things, or when you see us do it for induction, we may well offer the buccal route over the other. But most commonly for postpartum hemorrhage, you're going to see us place it rectally. That is because, one, we are already down there. We are usually down in the vagina massaging and things after a vaginal delivery. And also there's just not that airway concern for aspiration with the pills. We really can't place it vaginally if they're bleeding heavily because if you see people pass clots from the vagina, a clot could easily just wash a couple pills right out before they even have a chance to absorb or have any efficacy. So Misoprostol, 800 to 1,000 micrograms once in a mucosal surface, buccally, vaginally, or rectally. The main contraindication is an allergy to Misoprostol. Very few people have a known allergy to Misoprostol. And the main side effect that we are going to watch out for is transient hyperthermia. This doesn't usually give you a true fever, so not usually above 100.4, but it can definitely get you to the high 99s or low 100s in that transient hypothermia if you have to give them a big dose of Misoprostol for a hemorrhage. So just something to keep an eye on and be aware of. Make a mental note when you do that. That way, if you do see a slightly higher temp later on, you might be weighed in your clinical decision-making on how to react to that temp later on. All right, next medication is Methergine. And this is an IM injection. You give them 0.2 milligrams IM, and you can repeat that every 2 hours as needed. The main contraindication for this is hypertension. So Methergine can increase your blood pressure. So if you have particularly like preeclampsia with severe features or anything with severe hypertension, we are definitely going to avoid Methergine. If you're not severe or if your blood pressures are soft or low because you're hemorrhaging, it's a relative contraindication. So we may still decide clinically that it's worth doing it. So you can still see it given, but on your shelf and things, you would not give it to somebody who has hypertensive disorder, especially if you have alternatives. Hemabate is your next one. Hemabate, you give 0.25 milligrams IM, and this you can repeat every 15 minutes. The main contraindication for Hemabate is asthma. Hemabate, the brand name or the generic name is Carbaprost. That's probably what you'll see on your shelf and things, but the main contraindication of that is asthma. So if a patient has asthma, we can't give them Hemabate. It can cause bronchospasms and they can be significant. The main side effect for Hemabate is going to be diarrhea, and it can be quick and it can be voluminous, to the point that if you have a C-section with a hemorrhage and you are giving them Hemabate during the C-section, they can actually have diarrhea on the OR table before you're even able to move them over to a bed. So I always warn moms when I give them Hemabate that they may well have some very urgent bowel movements over the next few days. It's more significant. It's more worrisome for mom when she's had a C-section because moving is slow after a major abdominal surgery. And so it can be difficult, if not impossible, to make it to the bathroom in time. So we often will discuss with them and offer them something like a low modal afterwards to also slow down that GI stimulation if if they're worried about having to mobilize quickly to get to the bathroom for diarrhea. It can last about 24 hours and then usually subsides pretty quick. All right, so those are the main medications for Atony. So Pitocin, Misoprostol, Methergine, and Hemabate. If we make it through the medications, or we make it through the medications without contraindications, then the next thing we get to are things we need to do. So the first thing that we're going to do physically, like we talked about, was the bimanual massage. If that's not working and we've made it through our meds, one of the next things we can think about doing is a tamponade. So if I can't get the uterus to shrink down and come to me in terms of putting back pressure on its own cavity to put pressure on the bleeding, I can put something in the uterus and bring the uterus to that thing. So the original forms of these were balloons. You put a balloon in, you fill up the balloon with typically liquid, and you put back pressure on the uterus. So the sort of cheapest, easiest one of these is a Foley balloon. This isn't necessarily going to be large enough if you have a term uterus or a recently term uterus. So there are specific ones for term uterus. Bakri and Utah balloons are two of the biggest brand name ones out there. But there are some, essentially any empty balloon that you can fill up with liquid and then put back pressure on the uterus. We leave that in for 12 to 24 hours typically, and then slowly deflate it and take it out in hopes that the natural involution process of the uterus has reduced its size, reduced its blood flow, and thus reduced your blood loss when we remove it. There's a newer device. It is still a little bit expensive, but it works very well, and the data behind it is very good. And that is called the Jada device. This is a suction-based device. So it's a little horseshoe-shaped device on a stem. You put the horseshoe, and it looks like an upside-down horseshoe, up in the uterus. There's a balloon then at the cervix. You blow up the balloon to make the uterus a closed system. You can then put suction on that horseshoe portion of your device, and it sucks the uterus down to itself. So again, makes the uterus get smaller and put back pressure on itself with the help of this suction device. This can usually stop bleeding very quickly. It can be left in as little as 2 hours and up to the 12 to 24, but it works faster than the balloons because it is physically bringing it down to the right size rather than allowing the uterus to contract at a much larger size when it then still has to adjust. But like I said, it's like $1,000 currently, at least at my institution. And so it is, we try to pick and choose carefully who we use it on, simply because of, I think, of the cost and the, American medicine. All right, so put something in the uterus to help it come down to you. There are more options. Another thing you can do, we try not to do it in people who want to have more kids, but something called uterine artery embolization. This is where you then take the patient to IR, interventional radiology, and they make a small incision in the groin, typically to access the femorals, and snake their way up with fluoroscopy to the uterine arteries and put gel foam in the uterine arteries. If we block the blood flow to the uterus, this should reduce our blood flow. Your uterus also has significant collaterals that come down from your aorta to your infundibulopelvic ligament, your IP, and then across in your uteroovarian complex, and vascularize the fundus. So this is not all your blood flow to your uterus, but it can get a significant portion of the uterus and reduce your blood flow. The reason we don't love to do it on people who want to have future kids, there's not great studies looking at future childbearing after UAEs. And so we always worry a little bit about their future fertility and any implications for future pregnancies. That being said, if we're having to choose between doing a UAE and potentially having her hemorrhage to death, certainly a UAE is a far better choice. Finally, there are compression sutures that we can physically do. These are easy during a C-section, because obviously we already have the uterus in our hands. The first one is called a B-Lynch suture. Again, I don't think you'd be asked about any of these sutures, but you could certainly see them, and knowing their names is not a bad thing. So there's a B-Lynch suture in which it kind of looks like we're putting suspenders around the top of the uterus. We anchor them to the lower uterine segment, take them around over the back of the uterus, anchor it to the lower uterine segment in the back, pull it back around the front, compress the uterus, and then tie them super tight. This is supposed to just hold external pressure on the uterus, even when my hands are physically not there to hold pressure on it. There's a box suture, which is a similar idea. It's a front to back suture that just holds the uterus together from front to back. And then finally, there's an O'Leary Leary suture, which is sort of like a UAE in that it's a compression suture of the uterine arteries. So it's me using my actual stitch because I have her uterus in my hands to compress those uterine arteries and decrease blood flow. Again, limited evidence for future fertility in patients who've had to have O'Leary's, and so we worry a little bit about it. But again, certainly a better choice than risking losing her uterus or maternal mortality. So truly the last ditch effort here is a hysterectomy, removal of the full uterus to try and stop the bleeding and save the patient's life, if that is all we can do to stop the bleeding and save her life. Okay, so that is tone. Quick rundown on the meds. Oxytocin, Pitocin first. Misoprostol typically is second because it's shelf stable, room stable. It doesn't have to be refrigerated and it's really cheap. And there's a few contraindications. After those two, we typically go to either Methergine or Hemabate. Methergine tends to be more commonly the next choice if they don't have hypertension, simply because it has fewer side effects for people who don't have hypertension. And then Hemabate needs to be refrigerated. So that one is typically or often further down the choice. Then we have Tamponade with a Bakri Utah balloon, blowing it up in the uterus, or a Jada to suck the uterus down to a smaller size. Uterine embolization done by interventional radiology, or a laparotomy if you already have her belly open for compression sutures, or even a hysterectomy if needed. That is tone. We're going to move on to number 2 for the causes of bleeding, which is trauma. So sometimes vaginal delivery again, baby comes out, placenta comes out, and you're like, she is just hemorrhaging. But it's not happening necessarily when you put on fundal pressure, things like that. And you take a look in the vagina and you realize, oh my gosh, no, she just has a really bad laceration. And there's an artery that clearly got transected and it is pumping blood out of this laceration. You can have vaginal lacerations that bleed like this. Less common type of laceration that really can bleed badly, though, is also called a cervical laceration, where your cervix actually splits as the baby is dilating it. Typically for lacerations, all we're going to do is we're going to fix them surgically. We're going to put sutures in them. And then if that doesn't work, if it's just oozy, which sometimes happens too, we will do what's called vaginal packing or putting packing material into the vagina. The random thing you need to think about with this is when we pack the vagina, we're putting back pressure on the full 360 of the vagina, right? That includes the urethra. So if you're going to put packing in the vagina, you need to put a Foley in the bladder because we're artificially compressing her urethra and she probably will not be able to pee. That is trauma. Third one is tissue. Tissue typically takes the form of retained products of conception, so placenta or membranes. And this we often know once the placenta comes out. So if you're with me as a student, typically what I do is if you deliver the placenta, you are going to then examine the placenta. But typically whoever delivers the placenta should look at it. We need to make sure it's intact. We need to make sure there's no obvious piece missing. We need to make sure there's a reasonable amount of membrane. So typically I pull up the membranes and I try to make a little balloon out of them. Does it look like a baby could fit in here? Does it pass that gestalt? That looks reasonable to me, or it doesn't. There's not a measurement for this. It's just something you get used to looking at. If it looks like there aren't enough membranes, or it looks like there could be a missing piece of placenta, sometimes what we'll do is a manual sweep in which we take our hand and we sweep all the way up into the uterus to try and remove any pieces of placenta or membranes. We try to avoid this because obviously while you'll be wearing sterile gloves and a gown and things like that, the vagina and the vulva and the anatomy that's involved, none of this is sterile. And so we can introduce infection into the uterus by doing this. So we only do it if we really feel like we need to, but certainly is a good option, particularly for patients with an epidural. Without an epidural, that can be pretty painful. So a lot of things going into our decision-making for how to proceed with suspected retained products. You can use an ultrasound to look for them as well, to try and reinsure yourself. And then you can use instruments in the uterus to remove products if you're not able to do it manually with your hand. The fourth T is thrombin or coagulopathy. Thrombin is just what makes it work as a T, honestly. But any type of coagulopathy can lead you to bleed, right? Like if you're not able to make a clot, you're not able to stop your own bleeding, and you've got a huge raw placental bed that was hypervascularized to feed a term fetus. That now is just bleeding. So one of the best things for coagulopathies these days is TXA or tranexamic acid. Tranexamic acid is an antifibrinolytic, and it helps your body maintain its blood clots for longer by reducing your body's predisposition to break down. Your body's supposed to have a balance of making blood clots and breaking them down. This lets them hang out a little bit longer in people who are having trouble making and maintaining their blood clots. So TXA, we give them 1 gram one time. The other time you'll come in contact with TXA probably is major surgeries, and trauma is the big place. So this is a medication that started its life in trauma for just reducing blood loss, transfusions, and mortality, and has now made its way into a lot of bigger surgeries, spine surgeries, oncology surgeries, things that tend to be bloody, hysterectomies for us even, it has benefits. But for obstetrics particularly, there were some initial worries that it could increase your risk of DVT-PE because pregnant women are particularly at risk. They're already hypercoagulable, but the studies have not borne that out in trauma, which is also a hypercoagulable population, or in obstetrics. So it doesn't seem to increase your risk of DVT-PE. So we give 1 gram one time. If it's during a C-section, anesthesia can usually run it. And if it's during a vaginal delivery, one of the nurses can push it. And it's nice because, again, it's one time, it's not an infusion, it goes in quickly, and it works pretty quickly. The biggest studies that have been done on it show it reduces mortality. So mortality, death, like it actually can reduce your death from obstetric hemorrhage. So this is a great medication. It's becoming more common and more accessible, and thus the price is decreasing, which is great. So it's something you're going to probably hear about on your rotation, but some of your older resources may not include it because this is really a change in the last 3 to 5 years. Other things to think about as somebody is hemorrhaging, we are giving them fluids, right? And if you're in an obstetric room, like just a vaginal delivery room, we typically don't have our fluids on warmers, and patients are often naked to half naked, holding a wet baby covered in fluids. They can get cold really quickly. If a patient gets cold, their coagulation factors don't work as well. So if you're really passing that hemorrhage point and you're not seeing improvements, you got to think about making sure we're warming up the patient. Turn up the heat in the room, dry her off, get blankets on her, get a fluid warmer for any fluid resuscitation that you're doing to try to reduce the hypothermia from impacting your coagulation. And then we start thinking about other coagulation factors. Women around childbearing, or people around childbearing, have an increased risk of DIC compared to other types of hemorrhage. And in the obstetric world, abruption really increases your risk. So particularly for your shelf, they love to do this. They'll give you a patient, they'll give you either risk factors for abruption or a clinical scenario that sounds like an abruption, and then she'll bleed. And then they'll ask you what product she might need. If you think it's DIC, the right answer is going to be FFP to treat your DIC. We need to replace those factors, and FFP is going to be your most direct and easiest way to replace those factors for DIC. And then in some institutions, you'll have things like ROTEM or a rotational thromboelastogram, things like that are going to help you pinpoint what other factors you may or may not need to replace. Again, in the obstetric world, one of the things that's often overlooked is calcium. Calcium is really critical to many steps in the coagulation cascade. And people can get really hypocalcemic around the time of delivery because your uterus and your contractility of your uterus relies on calcium as well. So if somebody's really hypocalcemic, their uterus won't contract, they won't coagulate, and they're just going to bleed and bleed and bleed. So often if you're already transfusing somebody, you got to think about giving them back some calcium as well. All right. Again, a brief review of other random types of hemorrhage or causes. You might hear uterine involution, where the uterus turns inside out, think that like an inside out sock, and then it can't contract because it's in a weird position. Placenta accreta spectrum disorders and infections can also increase your risk of hemorrhage or worsen your hemorrhages. Quick rundown of the medications you're going to see in this. Misoprostol. So for a hemorrhage, Pitocin first, Misoprostol 800 to 1,000 micrograms, rectally most common. Methergine 0.2 milligrams IM, as long as you don't have hypertension. Hemabate 0.25 IM, as long as you don't have asthma. And then TXA, very few contraindications in the obstetric world. Prior MIs are a contraindication, and there's a few others, but thankfully there's not a lot in the obstetric populations. So most patients can get TXA. And then if you need to go further than just your meds, Tamponade, Bakri, Utah, or Jada device, uterine artery embolization or UAE, and then laparotomy with compression sutures and hysterectomy is your last ditch effort. And if you're asked about why somebody's hemorrhaging, Atony, 80% of the time, just don't think, just say Atony. The answer is usually Atony. that's maybe the one question you get during the actual wards. Most of the rest of this is stuff you're going to see. We're not going to ask you during an emergency, but you'll see it, and then it'll help you solidify it for your shelf and for later on in life if you decide to join us in the fun field of obstetrics. All right, if you have questions or anything, let me know. Otherwise, have a great day. Thanks for listening to Procedure Ready OBGYN. Hope you found today's podcast helpful. Don't forget to subscribe below, rate the podcast, and leave me a review. Your reviews seriously make my day, every time. Have you done your pediatrics rotation yet? We just launched a new Clerkship Ready Pediatrics podcast to help. We're always looking for new collaborators. If you know a phenomenal medical educator who should make a Procedure Ready or Clerkship Ready podcast for their specialty, pass along their information and we'll see if they want to collaborate. Finally, check us out at procedureready.com for more helpful resources like our flashcard deck and our YouTube playlist.